to go ahead, start recording. You don't have to show me your faces, but I always love to see faces, just because I kind of feel all alone here. But I do see your names and I respect if you don't want to, but it does make it more fun. Would love for you guys to interact because I think that's like, watching a video or just watching me do something that's helpful, but I think interacting with the content is always really nice. Oh, Shanavia, look at your face. Thank you. Oh, and Ashley, oh, you guys. Oh, thank you so much. And Taylor, hello, hello. It's nice to see your faces. Yeah, nobody cares about your hair. We're all good. And Amanda, oh, peer pressure. It's a wonderful thing. So with this study session, one of the things I was looking over the test, and I know I gave you guys the test plan that kind of says, the different percentages of what's on the test. You kind of know, there's certain chapters that would be, make sure you're studying more on those. Sorry, my son's heading off to work and he was doing a little dance. They might be able to see you, Mijo. He would be so embarrassed. Anyway, when I looked over the test, one of the things that stood out to me that I think students struggle with a lot is prioritization and kind of figuring out like, okay, this is a nursing school question and all the answers are right. Which one is the most right? It's really hard to figure that out. And that's a big part of nursing in general. Like when you guys go and start practicing, you're going to have a million things to do, or a patient that has a bunch of symptoms and you're going to have to know, okay, what do I address first? Which one is the most important? So that's kind of what I'm going to focus on today, because as we focus on those kind of prioritization things and looking at that, some of the other things that we're talking about come into play. So it might sound like we're like, well, why are we talking more about prioritization and not just the content? Well, the prioritization is going to be about some of the content, but I think helping you guys learn how to do this critical thinking piece is really a piece that will help you on the test. So one thing we didn't get time to do in class last week was go over some of those University of Maryland case studies that we have. And so I thought that would be good, just first of all, to just start and go over some of those, because I think that's really helpful. Oh, by the way, since we've not done these, I haven't done like really many Zoom videos, I think all with this cohort so far, just level settings for all in the same thing. This, like I said, I love seeing your faces. I'd love to interact. And so if you guys want to say something, please, you don't have to worry about raising your hand or anything. Just like unmute and ask, and like just like as much interaction I think as we can get. I think it will help you guys actually to interact with the content. The other thing is I'd like to keep it less than an hour, just to respect your guys's time. And so you guys kind of know. So by 5 o'clock, we will be done. I'll record, like I'm recording this. You can go back and watch again. Like if you have to leave, that's okay. Like this is optional. It's not mandatory. So just know like that's kind of level setting there. Any questions about what we're going to do? Not so much. My 3 heroes with their faces showing. Thank you. Okay. I'm going to go ahead and share my screen with you, and we're going to start on one of those, the University of Maryland. Do. Okay, so hopefully you guys can see the University of Maryland case study here. Yeah, okay, perfect. I want to, what am I doing there? Sorry, I'm adjusting things that you guys can't see. I apologize. Bum, bum,
The
bum.
NCLEX, is this kind of how it's going to be set up with these case studies?
Yeah, that's a great question. Yes and no. So traditionally, like when I took NCLEX a million years ago, I had a, okay, let me make sure. Do you guys still see the University of Maryland thing
Yeah.
on the screen? Okay, perfect. So NCLEX traditionally, well, actually, let's go back even further because history is fun. My mom is a nurse, and when she took her NCLEX, you had to travel to the state capital, and it was either 2 or 3 days of testing. And they had like multiple choice testing and dosage, and then there were all these essay questions. I think there might have even been skills. Like, can you imagine if we had to all go and stay in Olympia and do several days of back-to-back testing? Like, I, you know, I don't love the sound of that. And so eventually we transitioned, and now we had these like standardized testing, and it was, multiple choice essentially. So when I was in nursing school, we had multiple choice, and that was around the time I think when we added select all that apply, and everybody was like, oh my gosh, they're so hard. And they are. And what we found over the last few decades is that, multiple choice tests are they're good. They give you kind of an understanding, but it's hard to say, there's some students that just don't test well and they struggle with those types of test questions. And I've had students who I think would be excellent nurses, but just struggle with that testing format. And I think educators worldwide would probably agree with that. And so in the US, they said, okay, let's try to see how we can test clinical judgment. And so in that process, it's been about, was it a year since they've gone live with that? A little over a year. I'm trying to remember. They've put out this new thing where they have these next generation NCLEX questions. And so these question styles that you'll see, they introduce them. So we'll go through some of the different question styles, but they all kind of have this case study type approach where when you take your NCLEX now, you will have 3 case studies. Now, the minimum question amount is 85 questions, which I'm so excited to tell you guys. The cohort that just graduated, I think we've heard back from over 75% of them. And I want to say over 90% had their NCLEX shut off at 85 questions, which means they did really well because it can go up to 150 questions. It pretty much just goes until you either for sure pass or for sure fail. So that makes me feel really good knowing that what we're teaching you guys is preparing you to take the NCLEX. Anyway, going back, in the first 85 questions, you guys will have 3 case studies. These case studies will give you like a general bit of information, and then all of the next 6 questions are all based on this same scenario. Sometimes the questions will kind of add different things into the scenario. So it might say, oh, now we have vital signs for 10 o'clock and we have new labs or something like that. And but it's all about the same thing. One thing a student asked me a while back was about, well, what about if it says, which condition do I suspect? Maybe I think it's pneumonia or I think it's a UTI. If I choose pneumonia, then does it kind of tailor the next questions for that? Well, no, it doesn't, because the correct answer should have been UTI. So the following ones are all geared for that, if that makes sense. And when you take the NCLEX, sometimes, and you'll see in these scenarios, it will even say like, which do you like, maybe I'll say, which order do you anticipate? And maybe we say, well, I think we're probably going to need some antibiotics for this or something. And so then in our next question, we might have more information of, oh, the doctor ordered antibiotics. So there'll be clues to kind of help you. Even if you get it wrong, you can then go back and say, oh, okay, now there's antibiotic. That probably was right. So this is probably, a UTI, or, there's kind of context clues. Okay, I'm sorry, that was a tangent, but did I answer your question, hopefully?
Yeah, no, that answered it.
Okay, so yeah, so going back to your question, you will have a minimum, you'll have for sure 3 of these case studies in your test. So if you shut off at 85, you did so great, you'll have 3 of these. If you have more than 85 questions, you might have some more NCLEX style questions. So you might have some, but I don't think you'll have more case studies necessarily, if that makes sense. All right, so let's get going. So this one, I believe, is about pressure injury, which was from what we didn't really get to cover in class this week. Now, I didn't send it out to you because we're just going to read it together. So I'm just going to read it out loud. And it says, a nurse is caring for a 55-year-old female. Oh, no, this is burn. I don't want the burns. Sorry, we're gonna go back. I want the pressure injury. No, it must be this one. Sorry, I have 3 of them for us today. Okay, this is the one I wanted. All right, so a nurse is caring for a 19-year-old wheelchair-bound male who's come to the clinic with his mother for a routine checkup. When you look at these case studies, there's going to be like a general overarching theme. So this is what we know. It's a 19-year-old male. He's wheelchair-bound, and he came for a routine checkup. So that's our scenario. So now we have our nurse's notes here. And it says at 10 o'clock, the client received for routine checkup, accompanied by mother with whom he lives. The client has paraplegia secondary to a spinal cord injury. So just going back really quick, what is paraplegia? Let's make sure we understand.
Paralyzed, so you can't feel extremities.
Yes. And so usually when we're talking about like a spinal cord injury or there's something done, we talk about paraplegia or sometimes we say quadriplegia. So what's the difference between those two?
Para's 2, quad is all 4.
Yeah. So typically, paraplegia is somebody who does not feel or able to move anything below their waist, usually at whatever level of their torso or wherever that spinal cord injury occurred. Below that, they don't have much feeling or movement. So below his waist, he doesn't have much feeling or movement. All right, so client is alert and oriented ×3, denies any pain or problems. Mother is concerned about a quote, red area on his left heel. Then we have his vital signs. Temperature is 97.9. Pulse is 76. Respirations are 16. Blood pressure 112/68. Lungs clear with S1, S2, audible with no murmurs, gallops, or rubs. Just pausing really quick. Is there anything concerning on those vital signs right now? No, I see Amanda shaking her head. Nobody else. So yeah, they look pretty normal to me, right? I'm like, okay, I'm not really concerned. Bowel
Don't we
tone,
do alert and oriented ×4?
that's a great question. And it depends on, you know, different documentation styles.
Okay.
If typically, you're right. Typically, and we teach you guys alert and oriented ×4 because we want to know person, place, or time are typically the first 3. And what's that 4th one?
Person?
We got person,
Oh, person, place.
time.
Oh, I don't know the 4th one. I know if I heard it.
Is it the reason why they're there?
It's the situation. Yeah, it's the
Oh, yeah.
situation. Good job, Yesenia. Yeah, so we want to make sure they know because somebody might, they might know who they are and they might know the time and play like where they're at, but they might be like a little bit confused. They got knocked and they're like, oh yeah, I'm here to give a birth. And you're like, you're 74. Like we just want to make sure they understand why they're there. So in this situation, if I were taking this test, if it said alert and oriented ×3 and it didn't give me any other information, I'm going to assume that's person, place, and time, and that there's no disorientation to situation. If it said alert and oriented ×3, comma, disoriented to time or situation or something like that, then that gives me a little bit more information. But if this is all I have, then I'm going to assume that they're fully oriented. All right, so let's move on. Bowel sounds are hypoactive. Client has full range of motion in bilateral upper extremities with light touch sensation intact in fingers. No feeling or movement below waist. All right, so that's kind of what we figured with the paraplegia. Full passive range of motion bilaterally in lower extremities. Open area noted on left heel. Foul odor detected. Skin otherwise intact. Ooh. So of what we just read after the vital signs, is there anything that's kind of concerning for us?
The odor coming from the heel.
Open
Absolutely.
on the heel.
And the open area on the heel, which this is actually exactly what this next question is. This one says, which findings are the most concerning or are the most concern to the nurse? Select all that apply. So I absolutely agree. We said foul odor and open area. Is that right?
Mm-hmm.
All right. Is there anything else that we feel like is like kind of a big concern? When I say big, when I read these, it doesn't really say, I mean, we'd be concerned that he doesn't feel below his waist, but that's not anything new, right?
Maybe the light touch sensation in fingers, but I don't.
Well, what does that mean when we say light touch sensation?
Um, I mean, he
They
can
can
feel
feel
it,
like
but lightly.
Yeah. So he can feel, he's got sensation in his fingers. So sensation in his fingers, and the type of sensation is light touch. So he can lightly touch something and feel it, which is good, right? If it was like heavy pressure touch or like only like painful touch, like, that means his nerve conduction isn't working as well and he's not feeling as well. But if he can feel things just with light touch, that's good. That's normal. So that's a normal finding. Before I give you the answer, anybody feel like there's anything else here that we would be most concerned about, or there's a red flag?
So it says vowel sounds are hypoactive.
Yes.
So that's not good if it's hypoactive.
Right. It's abnormal. I'll tell you guys the answer. Open area and foul odor are the only two that are most concerning. And Shanavia, I love that you brought up the vowel sounds, because I think that's like on that path of critical thinking, because you guys didn't choose absence of feeling below the waist because that's expected for him, right? That's an abnormal finding, but that's not new. That's not anything that we're like, oh my gosh, like he's had that. But bowel sounds being hypoactive, especially if we think about he had a spinal cord injury. We don't know specifically where it's at, but depending on where it's at, that's going to affect some of his bowel motility, that nerve conduction. And he's wheelchair bound, right? He's in a wheelchair. He's not getting up and moving. So he doesn't have that type of mobility in his whole body that helps to increase peristalsis. And so people who are wheelchair bound usually do have a little bit of hypoactive bowel sounds, or it can be problematic for them because they're just not moving around and having the same activity that most of us would have. And they might have some nerve involvement depending on where their injury is at. So I love the idea, but it was not correct. That's okay. We're going to keep checking and going. All right. So let's go to our next question. Now, when you guys have these, this is a trick for you, or a tip. You don't have to read through all of these again. I think especially if English is your second language, sometimes the very act of reading through everything, it can take a while. I mean, or just anybody. So what I always do is I looked at earlier, we know this is the same scenario. The nurse's notes are from 10 o'clock. We already read through all of those. So before we go and read it all again, let's look and see what the question is. And if we need to go back and look at some of those nurses' notes, we'll reference them, but we're not going to waste time reading the whole thing again, just because the NCLEX, it's timed. You get about, I think it's a minute and a half per question. But there's a limit to the time. So you just want to make sure that you're not just spending extra time reading questions when you already read it. All right, so for this, it says, for each potential finding, click to indicate if the finding is consistent with a pressure injury or a venous stasis ulcer. Each potential finding may support more than one type of condition. Note, each column must have at least one response option selected. So what they're saying is we've got two types of injury. We can have a pressure injury, which we talked a lot about with skin, right? That's the pressure of somebody, I think especially like this man, like his heels, right? His heels probably had a lot of pressure and that caused the injury. We talked a little bit about venous stasis ulcers, and those are more when you don't have significant blood flow through an area. It's not about pressure causing the injury, it's that you just don't have as much blood flow. And so you can have tissue injury to an area because of that lack of blood flow. So now we're going to look and we're going to say, is immobility like we'll go one by one. We'll say, is immobility consistent with a pressure injury or with venous stasis ulcers?
Both.
Pressure.
Pressure injury.
I hear pressure injury from a couple people. I also hear both.
Both.
Both, yeah.
And you're right.
Both.
The correct answer is both. For sure with pressure injuries, but when we think of blood flow, if we are not moving around, our blood, right, it's not getting pumped through as much or as like it's just slower than if we're up moving around. There's not as much blood flow. And so it can be both pressure and venous stasis. All right, so next one, inadequate calf muscle function. So the muscle itself has some issue. Would that be something would be consistent with pressure injury or venous stasis ulcer?
Venous stasis.
Yeah, venous stasis, because there's some sort of muscle involvement, which means there's probably some issue with the blood flow. So venous stasis, pressure doesn't really, whether or not the muscle is functioning, that doesn't really have anything to do with the pressure injury. All right, located over a bony prominence.
Pressure injury.
Yeah, pressure injury. Now, anybody think that it's venous stasis as well?
No.
No.
Yeah, it's not, right? It's pressure injury. Good job. All right. The surrounding skin is brown or darker than normal and edematous. What does edematous mean?
Is it
Is it really
swollen?
swollen? Yeah. If we do word building, probably a lot of us have heard the word edema or swelling. And so edema, see, edema, and then tus is like referring to a state of it. So they have a state of being swollen. All right. So if we have darkened skin and we're swollen, is that going to be from pressure injury or a venous stasis ulcer?
Both.
Venous stasis.
Venous stasis.
I hear a little bit of a mix, and the answer is venous stasis, right? Because that, when the blood flow isn't going as well, you're going to have some swelling and the skin is going to be brown and kind of darker around there. With pressure injury, it's usually not swollen so much as, because sometimes it can even be flatter as that skin starts to break down underneath or the tissues do. All right, a shallow wound. You see a shallow wound. Could that be pressure injury or venous stasis?
Pressure.
Pressure.
Maybe both.
It's kind of hard to know, right? It's both. Pressure injury can start as a shallow wound, and so can a venous stasis ulcer. For this one, it's both. And then here, excuse me, tissue ischemia. And do you guys remember what is ischemia?
The death.
Mm-hmm. And we talk about tissue ischemia. What does that look like sometimes?
Black.
Mm-hmm. So do we think that could be pressure injury or venous stasis ulcer or both?
Both.
Venous stasis.
Anybody else?
I think both.
I think both.
I love that we're checking. It's actually just pressure injury. So think about that necrotic tissue that sometimes we see with the pressure injury, that black eschar. That's the tissue ischemia. And usually we would see that with a pressure injury where we have just, pushed, there's so much pressure, there's no blood flow and the tissue just dies. We typically wouldn't see that with a venous stasis ulcer. We're getting a lot of learning here. All right, so moving on. So here, I like it. We've got our same scenario and we have our same 10 o'clock nurses notes, but now we have a 10:15 note. So I'm going to skip over the 10 o'clock note and we're just going to read the 10:15 note. It says left heel wound measures 3.5 centimeters by 4 centimeters by 0.5 centimeters. No undermining present. Who can tell me what undermining is?
That's like the little holes and stuff, right?
close. So I think of like the holes, I think of like tunnels, under like tunnels, and undermining is when you have oh, I don't have anything good to show you. It's like if you have a nice cup of a wound, like if this is your wound, a side thing of it, and if the edges go over, then you have this undermining under, like you could reach down and it's not like a tunnel that tunnels in, but it's just like underneath the lip of the wound. Does that kind of make sense?
Yeah.
A little bit. Dear Ashley and Shanavia are nodding. I can see your faces. Thank you, girls. All right. Wound bed is pink. Slight foul odor detected. No drainage noted. Skin surrounding injury is pink, warm, and dry. Provider and nurse notified of wound. All right. And wound nurse, excuse me. So now we get to stage this wound. So thinking about our class, and we talked about different stages of wounds, if, and it's, the stages doesn't matter the size, right? Like this size, you can have a stage 1, 2, or 3 that's this big or this big. What is it as far as the circumference? What are we measuring really when we talk about measuring the wound? Or measuring or staging the wound, excuse me.
What was the question again? Sorry.
Yeah. So when we're looking at staging the wound, what are we looking at? Like what, it's not the size necessarily, but what are we evaluating?
If
The
it's
tissue that you
open,
can see. Yeah.
Yeah, like how much tissue has been lost or how much, how much through. So who can tell me what is a stage 1?
No skin breakdown.
No skin
It's just like
breakage.
red.
just
Okay.
pink.
It's
Pink.
red or like it's darker than the normal color. And then what do we want to make sure we like what's the difference between maybe a possible, like we're on the path to a pressure injury, but we're not there yet. It might be red or pink in both spots, but what else do we check?
That it's non-blanchable.
Yeah, exactly. If the area is red and we push down on it and it doesn't have like that cap refill where the redness goes away and comes back, if it is not blanchable, it just stays red the whole time, that is a stage 1. If it does go away, if the skin is blanchable, that's just somebody who's had pressure there and they're at big risk of having a skin issue. All right, stage 3, or that's stage 1. What is stage 2?
Breakage in the skin.
Yeah, you lose that first layer of the skin. And then kind of moving down, what do we hit with stage 3?
Fat.
We kind of that full thickness of the skin, excuse me. And then stage 4, what does that start involving?
Muscle and bone.
Yeah, we get real deep. So thinking about this guy, we already know how big it is, but it's pink, slight foul odor detected, no drainage. The surrounding skin is pink, warm, and dry. Where do we think he is?
Stage
Stage
2.
2.
Yeah, and I could see where you could almost say, well, is he a stage 1? I don't know how much skin is lost, but stage 1 is not an option. So our next, right? So even if you were thinking, oh, it's a stage, maybe stage 1, because the information we only have a stage 2. So you are correct. It is a stage 2 pressure injury. All right, we just admitted somebody else into our Zoom. Welcome. We're going over some NGN problems and really looking on prioritization, which you guys are doing really well. All right, so moving on, we have where we staged it at a stage 2, and now we have a wound nurse here, and she confirms that it's a stage 2. Good job, everybody. And so now it says for each order, click to specify whether if it's indicated or contraindicated. Each row must have one selection. All right, so now we're gonna go through and say, all right, do we want to debride the wound? Is that indicated or not indicated?
Not indicated.
Yeah,
Not.
not indicated. There's nothing there. It's the wound is pink. There's no, what did they say? Yeah, there's no indication that there's anything there like eschar or like slough or things that need to be taken off. All right, should we leave the wound open to air?
No.
Yeah. Why do
Yeah.
we want to cover it up?
So it doesn't get worse.
It doesn't get worse. It's not open to more things to maybe come and, infect it with something else, open to air. Good idea. Or not a good idea. A hydrocolloid dressing. Yeah. And then, hold on, I have my little answer sheet. Boom, boom, boom. The reason why the hydrocolloid is that it has kind of a moisture to it. And it does say that there's no drainage noted. If it was draining a lot, we might want a dry dressing to kind of wick away some of that moisture. But this one actually is pretty dry. And so we want to have moisture there to promote the skin being able to heal and grow back. All right, do we want to clean it with saline?
Yes.
Yeah, it's probably a good idea just to wash it off, clean it with saline, and start IV antibiotics. I see Amanda shaking your head no. And correct, we do not need to start antibiotics at this point. They might order topical antibiotics and see how they respond. Remember, antibiotics, if they're anything that's given orally or in our IV, that's going through our whole system. And he probably doesn't need a whole system cleanse with, getting rid of bacteria. He just needs local right now. All right, so going to the next one, let's see. We've got the same notes, so we're not going to reread those. Oh, we have orders now. Cleanse, heal wound with normal saline. Good job, you guys. And dress with hydrocolloid dressing. Client to return in 2 weeks after follow-up. All right, so the nurse receives wound care orders. What 3 actions should the nurse teach the family about wound care? So we're going to be teaching the mom who takes care of him how to take care of this. So, and I like that this question gives us 3 actions. Make sure to read through because some of these questions will say, what should you teach the patient? And some will say, what 3 things? So I like the ones that give us the numbers because it's really precise. So let's go through and see what we just off the top, what do we think is correct? So wash hands prior to dressing changes.
Yes.
Yeah, I agree. I think anybody disagree with that one? All right, massage the right heel every evening to promote blood flow. I see some head shaking. No, we really don't want to massage those areas. Monitor for signs of infection.
Yes.
Absolutely. What would be some signs of infection that we could see?
Redness, the wound expanding.
It's growing.
Drainage.
Yeah, if they starts having drainage there for sure. All right, elevate heels when in bed.
Yes.
Yeah, why would we do that for him?
Circulation.
Kind of.
To take the pressure off the wound.
Yeah, he already has well, if my hand is the heel, but like if he already has pressure or a pressure wound on that heel, we want to prop up his heels first so there's not pressure on that wound directly. And then second, so we don't make it worse or cause another injury to the other heel. All right. Eat a diet high in complex carbohydrates.
No, it's protein.
Right. Yeah, we want protein. And apply a cold pack to the wound if swelling occurs. What is ice or cold packs? What do they do to the blood vessels?
Constrict them.
And we really don't want to constrict with him. We want to make sure there's good blood flow moving through there. So good job, you guys. Those are the 3 things. All right, last question with this one. We have a new note. So let's read this. At 10:45, The wound was cleansed with normal saline solution and a hydrocolloid dressing applied. Client's mother educated on how to clean the wound and change the dressing. The treatment plan discussed with client and his mother. Client is to return in 2 weeks for follow-up. We have orders to cleanse the left heel wound with normal saline and dress with hydrocolloid dressing and for the patient to return. Okay, so progress note. Seen in clinic for follow-up of a stage 2. Okay, so this is the 2-week note down here that we're seeing. Wound measures 3 centimeters by 3.7 centimeters by 0.2 centimeters. No odor, drainage, or signs of infection. Skin surrounding the wound remains pink, dry, and intact. So just off the top of our heads, do we think he's doing better or worse?
Better.
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 Yeah, and if we can't remember even how big the wound is, well, now is the time when we can go back up to the top and be like, oh, yeah, here it is where his wound was 3.5 centimeters by 4 centimeters by 0.5 centimeters. So it is getting smaller. So now it says the nurse determines the client status is, and we said he's getting better. So we're going to choose improving. And then it says, and the nurse should now, oops. So now, do we want to call the wound nurse to recommend a change in treatment, Claire? Excuse me, recommend use of vacuum assisted closure system, or reinforce wound care interventions and pressure injury prevention strategies?
Reinforced wound care.
wound care.
And yes, absolutely. I was just double checking to make sure we are correct. Yeah, because now that he's getting better, we want to make sure they don't have any questions, they're doing things well, and we want to try to prevent him from having more pressure injuries, because we know if he already had a pressure injury, he's more likely, like he's more at risk to get one, because honestly, just he's got paraplegic, right? He can't feel if he starts having some skin breakdown, and he's wheelchair bound, so there's bound to be areas of pressure. So we want to do some good teaching with that. All right, I think that was the last question for this one. Yay! All right, how did that feel about starting to do some of that prioritization?
Not too bad.
Not too bad? Okay. Let's get into a little bit more here. I've got, let's see, this one is, okay, urinary incontinence. All right, we're just going to jump right into this. And let me see, who all is here? I've got, felt like somebody else came in that I couldn't see. All right, well, I'm glad you guys are all here. Whoever is here, thank you for being here. All right, so I'm going to go ahead, and this is same type of thing. It's another case study. It's a grouping of 6 questions that all follow a scenario. So our scenario is the nurse is caring for an 82-year-old female admitted to the medical unit with dehydration and new onset of urinary incontinence and mild confusion. All right, so we have a nursing note of 9:30. Oof, it's a long one. Admitted from the emergency room with dehydration and new onset incontinence and mild confusion. Recently widowed and now living with daughter and son-in-law. Daughter reports declining PO fluid intake in the past week, and now client has foul-smelling pink-tinged urine with new incontinence and a low-grade fever. No reports of pain or burning, but noted to be restless with new onset of mild confusion. All right, well, I'm glad she's here. Upon admission to the medical unit, she's alert and oriented to person only, but pleasant and cooperative. Temperature 101.8 Fahrenheit, other vital signs stable. Skin dry with poor turgor. Do you guys remember what turgor is?
Yes. So that is where you pinch the skin and almost kind of like you're checking for cap refill, but in another place. Or no?
It's you pinch the skin, it's another place. Anybody else want to kind of help out?
Yeah, because it's dehydration. It should come back
We're
and
checking
not
for
stay tented.
dehydration. So where do we usually check for skin turgor?
On the chest area?
It's usually, it can be in the chest, or we do in the back of the hand. And you just kind of pinch, let me see, you just pinch And then see how my skin, I'm pinching it up, but it just goes right back down. I'm young, ish, it's all relative. But I'm youngish and I still have enough fat in here to get the, anyway, and I'm hydrated. And so my skin goes right back down. In our elderly, especially if they're dehydrated, we could pinch that skin and it would just stay what we call tented up. And so it does say poor skin turgor. What that means is there's probably some tenting, which makes us think there's probably some dehydration. And then it also says neck veins flat. What does that mean?
They're not visible, pointing out
Yeah, I
she
mean,
is
it's kind of,
dehydrated.
it's a weird way of saying it, but when we have like our neck veins, sometimes if I get like really excited, my neck veins will stick out. Or sometimes if people are hypertensive, sometimes we can see their veins sticking out. Hers are very flat. It's not one that I would say people should look for all the time, but if they're telling us that, that's just another clue about what's happening with her. So reading on, we offered the bedpan frequently and voiding small amounts of urine, concentrated, pinkish, and foul smelling, does not report burning or pain. Urine and blood cultures obtained, results pending. Daughter reports a sulfa allergy. All right, good to know. So here we have her vital signs at 10 o'clock. We already know her temperature is elevated. Our pulse is 96. Respirations are 18. Blood pressure 105/52. And oxygen is 97 on room air. We've got some labs. BUN is 27, which the high end of normal is 20, so that's elevated. Creatinine is 1.3, which is just under normal. So it's normal but high. White blood count is 11.1, which 10.5 is normal, so it's a little elevated. Potassium is 3.6, so a little low, but still within normal. Sodium, 143, within normals. 4+ bacteria and white blood count over 10 with hematuria in our urine analysis. Normally in a urine analysis, you don't see any bacteria, no white blood count, and there's no hematuria, which, what is hematuria?
Blood in the urine.
Yeah, it's blood. And then we have a lactate of 1.2, which is normal. So now this is one of those nice boxes, or these nice that says, what are the four findings that need immediate follow-up? So that was kind of a long thing that I just read through. Did anybody have kind of red flags that stood up? They're like, ooh, I don't like that. That was not good.
Temperature.
Yeah. Anybody else agree with that? I see Ashley nodding. So I agree. I think temperature of 101.8, that's pretty high. Where is that at? Here we go. All right. I'll let you kind of look here at some of the other findings. Oxygen saturation, incontinence,
Foul
White
smell.
blood cell count.
the white blood cell count. Yeah, that one that's pretty high too, right? I would be concerned about that. Where's that at?
Skin
Uh,
turgor.
Skin turgor, yeah. And then foul smelling urine.
Yeah, anybody else agree or disagree with those two? Skin turgor and foul smelling urine? Yeah, and I think these are really smart, right? Because if we look at these, her temperature clearly is really high. That's a kind of an easy red flag. So if I were going through this, that'd probably be one of the first ones. Yes, that's real, but that's not good. So anytime our temperature is high, what are we thinking about?
Infection somewhere in the body.
Yeah, and based on her history, where does she probably have an infection?
UTI.
Yeah.
Yeah, and actually, we chose foul smelling urine. That's another clue that's saying this is probably the source of infection. And then when we're looking at infection, we also have our white blood count. And that's not just the white blood cells that are in our urine, but our white blood count that's in our serum, which is like blood. That means the whole body is responding to this infection. And then you guys are right on with skin turgor being the fourth one that we'd want to check because she looks to be pretty dehydrated, which is going to add to everything. Now, everything else is fairly normal on here, except the incontinence, that's new. But if we're going to say what needs more immediate follow-up, we're going to be managing that incontinence, and hopefully that will be resolved once we take care of these other things. So good job identifying these. Look at you guys prioritizing. All right, let's move on. So we still have the same scenario, the same nursing notes, the same vital signs, but now it's going to say for each of these findings, indicate if it's consistent with the condition of dehydration or urinary tract infection. So it's kind of wanting us to kind of parse out what do we think is causing it. But just like that question you had before, it could be both. So when we have increased white blood cells, do we think that's being caused by dehydration or the UTI?
UTI.
Oh, sorry, I clicked on the wrong thing. My bad. Anybody have any other thoughts?
I think it could be dehydration and urinary tract infection.
Mm-hmm. Sorry, I'm getting to my little cheat sheet. It's not letting me like move over where I want to go. Okay, there we go. I just want to make sure I told you guys the correct thing. And it's urinary tract infection. That's going to be typically where we see increased white blood cell counts. I will say you're right. If we're really dehydrated, we might see everything be slightly elevated because it's all more concentrated, but we usually don't get above normal. It might just be like a high normal, if that makes sense. All right, so flat neck veins. Do we think that's dehydration, UTI, or both?
Dehydration.
Dehydration.
Yeah, for sure, for sure. All right, now we have recent poor PO or oral intake. What does that fall under?
Dehydration, and then that's what could be causing the urinary tract. Actually, no, just dehydration.
Anybody else have thoughts?
Dehydration.
Yeah, I think for sure dehydration, but urinary tract infection also could be part of this recent PO intake. Remember, in older adults especially, sometimes we have just some changes that can happen. Confusion, sometimes loss of appetite can be part of that. And so that UTI could be what's causing her not to eat and drink as much, especially she said there wasn't any burning while she was peeing, but she was having to go a lot, which is a very common like urinary frequency or going like very frequently can be very common with urinary tract infections. And so sometimes people will say, I'm going all the time. I'm just going to stop drinking because I don't want to keep going all the time, not realizing they don't realize it's because of the infection, not that they have too much fluid in them. All right, so the elevated BUN, do we think that's dehydration or urinary tract infection?
Urinary tract.
Dehydration.
Yeah, dehydration. So with the elevated BUN, that's usually more related to a concentration. Like the urine is more, or the serum levels, like the blood levels are more concentrated. If the urinary tract developed into a kidney infection and we had kidney involvement, we might see it, cause the BUN to elevate, but typically it would just be dehydration with a simple urinary tract infection. All right, new onset of incontinence. Which one do you think that's causing or from?
Urinary tract infection.
Yeah, right? I hope everybody hopefully has that settled into their brains. Like when somebody, especially older adult, and they start to be confused out of nowhere, we're going to check their urine. Oh, wait. I just answered the second one. Okay, on new onset of mild confusion. Which do we think that is?
UTI for sure.
Yeah, I know. I totally read the wrong one. Oh my gosh. Okay. Okay. And then concentrated urine. Her urine is more concentrated. Do we think that's from dehydration or UTI?
Dehydration.
Yeah, both, right? She's dehydrated. It's going to be more concentrated. And with the urinary tract infection, she's not wanting to go as, yeah, it's both. So good job. Okay. Moving on. We have the same scenario, same labs, same vital signs. Which problem should the nurse address first? Okay, this is a perfect prioritization, right? Because all of these are correct. It's confusion, dehydration, urinary tract infection, and incontinence. So all of those are issues, right? We want to address them all, but what do we need to address first? Anybody have
The-
Dehydration.
ideas?
Confusion.
Dehydration,
Ooh, I heard a couple. I heard dehydration. What else do we say?
Confusion.
Mhm. So I love this because I think it all comes together. So what do we think is kind of the starting point for all of this? What do you think kind of caused all of it?
The UTI.
UTI.
Yeah, I really think
Dehydration.
I mean, right, like chicken or egg, right? Which do we know? We know for sure that she has a UTI. Or not, yeah, I mean, yeah, we do know that. My guess is that's causing the confusion, the incontinence. If anything, it's contributing to the dehydration. But when we say, what do we want to address first, right? That's telling us now we've got to think critically, because when it says address, what does that mean?
Like kind of take care of first. And the way that I kind of think of it is if we give her fluids, then we can manage the urinary tract infection after, because once she gets her fluids going, that's kind of where I'm thinking then everything else is going to kind of fall into place, because you can give her meds while she's on fluids.
Getting the fluids. Gotcha. And I love that thinking, because in the real world, we probably are getting her, like we're getting an IV started, we're going to give her fluids, we're probably going to start antibiotics, we're going to be doing all of those things. But in a testing world, it's saying we've got one problem to address first. And I want to go back and look really quick, because with the dehydration, we do look at some of these vital signs to tell us how she's compensating. How is she handling the dehydration? So what vital signs do we look at to see how she's managing the dehydration?
Blood pressure.
the temperature.
Right, temperature could go up with dehydration, but usually not that far up, but blood pressure for sure. And then also the pulse, right? That can also give us an idea. And I would say her pulse is a little elevated, still normal. Her blood pressure is a little soft, meaning it's a little bit low, but it still could be normal. She seems to be doing okay. So when we're looking at these, really, it's the UTI that we want to address first. I totally understand, Chris, where you're coming from of saying the dehydration, but her body is handling the dehydration okay right now. She's compensating with that. The infection, though, that's probably not going to get anything but worse as we continue to let it on. So this question is saying, if we only get one thing to do right now, even though in the real world, we do it all at the same time, but it's asking us, if you had to make a choice, what would we choose? And the correct answer is, we're going to treat the urinary tract infection. Any questions with that? And especially anybody who maybe thought differently on it? Not so much. Okay.
You explained it, but it's in the real world. If you reason to the real world, it's not still clear, because definitely you're supposed to. It's like giving a medication without somebody having anything in their stomach for the past few days. If they are dehydrated, they need to be hydrated before you start treating it, right?
Good and great question, Agnes. Right, and I would say most likely they're probably going to start her on an IV medication, but you're right. If we're going to give her an oral medication for antibiotics, we probably would want to give her some food or something with it. And so I hear you, but still our aim, our goal, the very first thing we're working at is that infection.
Got it. Thank you.
You're welcome. I'm so glad you said something. It's nice to hear from you. All right, so number 4 of 6, we've got our same scenario, same vitals and labs, but now we have orders. We have administer 500 mils of normal saline IV now, and then normal saline at 75 mils an hour. So we want to give her like we call it a fluid bolus, right? We're going to give her kind of a bunch right now, and then we're just going to give her a little bit at a time from there. Also says administer ciprofloxacin 200 milligrams IV now and every 12 hours, and administer acetaminophen every 4 hours PRN for temperature greater than 101. So we look at the orders and we say, which should we also include in the plan of care? So we know that we're going to give her fluid bolus, antibiotics, and we're going to give her Tylenol for the fever. Those are all the things we were kind of talking about. What else do we want to include? So let's go through these kind of one at a time. Do we want to have her on strict bed rest? Yeah, I see some head shaking. Probably not. Why not?
Don't want her to get pneumonia.
Right? We don't want her to get pneumonia. We don't want her to get blood clots. We know it's not really healthy for people to be on bed rest unless they have to be. Encourage PO fluids. I see some nods. Yeah. Why do we want to encourage the PO fluids?
So she's not dehydrated any longer.
Yeah, we really want to make sure she keeps hydrated, right? If we can get her off of the IV fluids, if she's taking enough oral, that's better for her. I'll click that. Document intake and output.
Yes.
Yes, thank you, Shnavy. Absolutely. We really want to know what's coming in and what's going out. Monitor urinary color, character, and odor.
Yes.
Yeah. Why do we do that?
Make sure the
Because-
infection. Go ahead.
Right? Yeah, it's going to tell us about just like the wound we looked at in the last scenario. It's going to tell us if it's getting better or worse. You know, if the urine is getting more concentrated and dark or more foul smelling, it's probably whatever we're doing hasn't been effective. But if it's getting more clear, it's not as foul smelling, that means we're moving in the right direction. What about requesting an order for a Foley catheter if she's incontinent?
Wouldn't we only want to do that if none of the interventions we were doing are working?
Yeah, so test taking tip for you and real world application. We just don't put in Foley catheters hardly at all anymore. So if it's giving you a choice of put in a Foley catheter or don't put in a Foley catheter, unless you have a clear reason why you should, it's probably going to be don't, because there's such a high incidence of infection when we put in Foley catheters. And she already has an infection, right? What would be a good reason to put in a catheter?
If she just wasn't going at all, or we weren't able to get her to go, I guess.
Yeah, if she was retaining urine, if she couldn't pee, you know, she's trying to pee, we're
Or
bladder
she's
scanning her.
rested.
Or what was that, Amanda?
If she was restricted to the bed, like bed rested.
You know, even with bed rest, we put people on bedpans. We do PureWick if they're allowed. I would say another good reason or like if they have strictures or somewhere where they can't pee on their own, sometimes they will, or sometimes if they're in critical care and we want to really closely monitor I&O, that might be a reason. But generally, if you see this on a question on a test, it's going to be no Foleys. Like that's just a big initiative over the last couple of decades is that we've realized Foley catheters lead to infection. So that's a good test taking strategy. Unless you can figure out a reason why you should put it in, like that really would be beneficial, we'd keep it out. All right, apply PRN oxygen at 2 liters per minute per nasal cannula. Let's go back and see what was her O2 sat. 97. How are we feeling about that?
Okay.
No.
Right? Like that's you and me. That's good. She doesn't need that oxygen. So good job. You guys are correct in all of those. All right, so question 5 of 6. So now we have the orders, we have everything else, so nothing has changed. What action should the nurse take before administering the prescribed antibiotic? All right, so what's that?
We should always want to review the allergies because when she first came in, there was a reported allergy of sulfa, I think.
Oh, good remembering. Yes, she had, the daughter reports a sulfa allergy. So anybody, so this is saying there's which, it's kind of like a which one action. Anybody think it should be one of these other ones? Monitor hourly urine output, check pulse ox, or document blood pressure after sitting and standing? No? Good job. And especially, so if we're thinking about this with medication, you've got the 6 rights, right? And so if we're going to go through, we want to always check, and I guess allergies is kind of grouped in with that. It's not, but that's one thing we always do. So this makes sense to me. These other ones, we might want to do these, but they're not directly attached to the antibiotic. All right, so now we have some more notes. At 10 o'clock, we gave the first dose of Cipro and the IV bolus and Tylenol. At 1400, her vital signs were stable, her temperature down. IV was down to 70, went down to 75 cc's an hour. She's resting quietly. Fluids are encouraged. Offer bedpan frequently, avoiding slightly more dilute yellow color urine. That's good. 450 mils since fluid bolus. And then we have day 2. At 8 o'clock, vital signs are stable, afebrile, alert and oriented to person, place, situation. 850% of breakfast, refusing most IV or most PO fluids. IV normal saline at 75 an hour, continent and voiding clear yellow urine. Family with client since last evening. We've got some more vitals and more labs, but I kind of want to go down and just see what they're saying. They want to know, is she improved, declined, or unchanged? So this is going to be where we decide, it's a little bit of that critical thinking. How is she doing? So the urinary color and character. How do we feel about that?
Improve.
Yeah, improved. It's less concentrated. I agree. All right. What about the confusion?
Improved.
Improve.
Exactly. Improved. She's not as confused. She's actually oriented. What about the PO fluid intake?
Unchanged.
Decline.
Yeah, it's kind of unchanged really, because it said earlier she wasn't taking very much PO in, and now she's not still. So it's kind of unchanged for this one. Her pulse oximeter.
Unchanged.
We can go look and see 97, 97, 96, 97, 97. Yeah, unchanged. It's pretty much the same. And if you have like a 1 or 2 point difference, it's the same, right? Her fever. Oh, let's go look, because she was 101.8. Now she's 98.4.
Improved.
Yeah, so she's improved. Her white blood cells, let's go look. So let's see, white blood cells were 11.1. Now they are 9.5.
So they're improving.
They're improving, right? It's always nice. And I love that the NCLEX now gives you guys reference ranges. So you can go over and say, okay, here's what normal should be. Now this is within normal. Her continence, which means like if she's incontinent or not. And I believe they said it was improved, didn't they? Yeah, she's continent now. So that's improved because she was incontinent, wasn't she? Her BUN was 27, now 19. What do you think was the biggest cause of that, or what helped it to get normal?
Antibiotics. Or
Receiving fluids.
The fluids, right? Yeah, the fluids. Your BUN is going to get really concentrated when you're dehydrated.
oh,
That really lets us know about dehydration. So that fluid bolus, as well as the fluids she's been getting, that's what's really helped bring that BUN down. But it is improved, right? The number's better. Creatinine. let's see. Now creatinine, that's the one. So the BUN really tells us, I mean, the BUN tells us about the kidney, but it really is very susceptible to dehydration. Creatinine tells us about kidney function as well. It's not as susceptible to the dehydration. So when we go look at creatinine, it was 1.3. Well, it's still 1.3. That's partially why when we go and look at some patients, if their BUN is really high, but their creatinine is normal, they're both looking at kidney function. And if I look at this patient, I would say, ooh, the creatinine looks good. I wonder if they're just dehydrated with this BUN. And so once we gave them a little hydration, this is very typical what we would see with the BUN coming within normal limits here. Okay, so the creatinine unchanged. All right. I think last one. Okay, I know I said we're going to be done at 5 and we're not done at 5. I have 2 more questions I really want to go over with you guys. So if you want to stay, feel free to stay. You do not have to, but I found 2 questions on this other UNM that just really talked about prioritization. So if you have time, hang with me just for a few more minutes. All right, so this one, it's a little more complex. We're not going to go over this whole case study because this one is really geared specifically more for RNs and some stuff that you guys haven't even covered yet. But I'm going to kind of skip through the questions that I think are really helpful for us, especially, like I said, with this prioritization. And it's about burns too, which we covered. So with this one, we have a 55-year-old female admitted to the burn unit after a house fire. So at 8 o'clock, she came into the emergency department via ambulance with bilateral 2nd and 3rd degree burns to the front lower extremities from a house fire that occurred at 1800. Burns are estimated at 36% of total body surface area. The client weighs 220 pounds. Fluid resuscitation started with Ringer's lactate IV. At 2100, so 1 hour later, she was admitted to the burn unit. Vital signs as noted, morphine sulfate given for pain. Wound care was provided by the nurse. Breath sounds are clear. Bilateral 2+ pitting edema was noted in the lower extremities. Doppler pedal pulses present. All right, so it gives us kind of an overview of how she's doing. If we look at her vital signs, we can see her temperature was elevated when she came in at 100 degrees. Now it's 99.5. Heart rate was 130. Now it's 135. Respirations were 28. Now they're 32. Blood pressure was 88 over 58. Now it's 80 over 54. Pulse ox was 92% on 4 liters, remained the same. Her pain was 6 out of 10. Now it's 4 out of 10. This little box talks about the fluid resuscitation. We're not going to really go over it a whole lot, except for it does say output. And at 8 o'clock, we had no output. And then after 600 mils of fluid in, we only had 20 mils of urine out. So now we go down, and this is where we talk about prioritizing. There's a lot going on with this gal, right? She's kind of sick. I mean, she has these burns that are pretty bad, and there's a lot going on with her. And we want to say, what are the 4 findings that are urgent to follow up with? All of these things we need to address. But what are the 4 that are most important? So when you looked over this case study and when I was reading it, what stood out to you as those red flags?
Her blood
rate.
pressure.
Blood pressure.
I heard blood pressure. Anybody agree?
Yes.
Yeah, I don't like that blood pressure at all. I didn't like it at 88 over 58, and I sure don't like it now that it's going down at 88 over 54. You know, I'm really concerned about that. So I for sure would grab blood pressure over here. Looking through some of these other things, anything else that kind of stands
For
out to you?
respirations.
Respirations is one. Anybody else have thoughts on that?
Yeah.
I agree.
Yeah, I agree.
You agree?
Heart
Okay.
rate is high.
It is pretty high. We can put that over there. Was that another one that somebody said? I couldn't quite hear.
Heart rate.
The heart rate. Yeah, the heart rate is really high. I agree.
And then
The urine output.
I would say the pulse ox, actually. Yeah, maybe the pulse.
The urine output.
And so what do you guys think? Let's put this to the group. So let's talk about it. Like, so we're saying we're kind of going between the urine output and the pulse oximeter, right? And just so you know, you guys are correct. Heart rate, blood pressure, and respirations are all correct. So good job. And this is nursing school, right? It's like they're all correct. Which are most correct? So it's the blood pressure for sure. I think that's the easy one to pick out. And then you look at heart rate and respirations, and I think those two are also pretty easy to pick out as well, because you're like, man, she's breathing really fast, and that heart rate is high and it's going up. So you pick those first three out really well. And now it's the tricky part, right? It's the last one where you're going, okay, now which one is the more acute, okay? And so when we're talking about urine output and the pulse ox, let's look at those two. So oxygen wise or respiratory, 92%. How do we feel about 92%?
That's okay.
Yeah. Anybody else?
Not too consigning, but a little bit, but not, that's not the main issue. The output should be more consigning.
Yeah, I kind of agree with you guys, Agnes and Shanavia. Thank you. I think I don't like that it's 92%. I don't like that she's on 4 liters of oxygen, but that's okay, right? It's a low normal. It's, you know, she's doing okay. The other one, I think Amanda, you had said that we're concerned about is her urine output. So we've given her already at least 600 mils of of fluids after getting, oh, I think she also, oh no, she got 1200 mils of urine. So she's got a lot, she's had a lot of fluid going in, and she only has 20 mils coming out. How do we feel about that?
Yeah, I agree. That's pretty low for the intake that she's been given.
It's really low, and I'll say the urine is the correct one. Shanavia, I saw your message. Totally fine. Thank you for coming. So yeah, the urine is correct because one, that's a really low urine output, right? And we've given her a lot of fluid. We know that one of the big risk factors for burns is dehydration, right? That's just something you lose a lot of fluid when you have burns. But only having 20 mils of output means that we're not getting her enough fluid. Either we're not getting her enough fluid, or maybe her kidneys are having an issue right now too from something that happened. So she's not doing as well. If you got, what's the minimum amount of urine we want to have every hour for a healthy patient?
30.
30, right? So she's not even hitting the minimum for 1 hour here. So if we're going to say, I don't know if it's respiratory or urinary or the renal, you know, respiratory, I don't like where she's at with that 92%, but the urinary, that's way below, that's below normal after giving her all these things. That's definitely the more concerning one. And I think this, so urinary output that's our last one. And it doesn't really have us rate them. It just wants the 4. That's why I really wanted us to do this question, because I think that's part of this piece where when we think about what's concerning or what's a urgent follow-up, we usually talk about ABCs, right? Airway, breathing, circulation, which is good, but if her airway and that breathing, if that's doing okay, then we're going to look through the rest of her system and see if there's anything else that's a little more concerning. Does that make sense to everybody, or anybody have questions? Not so much? Okay. I'm going to skip through because these, let's see. I don't want to do the rest. I just want to go to question number 5. The other ones were just kind of complicated, and really the 5th question I think is better. 4. And I'm just randomly selecting. So please, if you're looking at my answers, they're not the correct ones. Okay, so here we've got our notes just like before. We have our vital signs just like before, and we have our intake and output. Now we have our orders. So our orders are to get a chest x-ray, ABGs, and a complete metabolic panel. We want to get some labs to see where she's at. Oxygen per nasal cannula from 2 to 6 liters to maintain a pulse ox at 92 or greater. All right, so even the doctor who's ordering these is saying 92 is our goal, right? We might not be able to get a whole lot higher than that. We want to titrate the IV fluids based on urine output up to a maximum of 2,000 mils an hour. Guys, that's so much. If the urine output is less than 15 an hour, we increase the IV rate by 20%. 15 to 29 mils an hour, increase it by 10%. 30 to 50 an hour, which we said 30 is the minimum for healthy kidneys, right? We just leave it the same. And if we have over 50 an hour, then we decrease it a little bit because we know we're probably giving more than she truly needs. We also have an order for give 500 mils of 5% albumin over 2 hours as needed for systolic blood pressure less than 80 or diastolic blood pressure less than 50. I know we haven't talked about albumin a lot, not yet. We'll probably cover it more with blood products, but that's just one that helps with like volume expansion. She's probably using up a lot of albumin with the burn. So now we have these orders and it says which of these should take first, should we do first? So this is another prioritization. So we have obtain the chest x-ray, obtain an ABG, increase the IV rate, or give the albumin. So they're all 4 things we need to do. Does anything stand out as something just to start eliminating? What could we probably put to the end of our list?
Chest x-ray.
Yeah, I don't think that's as urgent right now. Anybody disagree? Nope. All right, so let's scratch off chest x-ray. We need to do it, but we're going to put it at the bottom of our list. All right, is there anything else that we could kind of put at the bottom of our list?
ABGs, maybe.
Yeah, kind of the same thing when we're looking at her, like as far as what we know, you know, from her lung or pulmonary status, she's doing okay. Not great, but she's doing okay. We still, and just as a reminder, her blood pressures are not great. We haven't changed. 80 over 54 and a heart rate of 135. So I agree with you guys. If I was looking through these, I would first say, okay, chest x-ray, ABG, yeah, I'm going to do them, but they're not my first things. So now we say, do we increase the IV rate or give the albumin? Anybody have any thoughts?
The
we
IV.
probably wanna- yeah.
Increase the IV rate.
Well,
The
I was
IV
gonna
rate.
say albumin because of the blood pressure, because at the bottom it says 2 hours as needed.
Yes, you're right. And I think this is where I think most nurses would get a little bit tripped up. So that's why I wanted to look at this question with you guys. Because even though we haven't talked about albumin, it's that thought process that goes through it. So yes, the doctor is saying, give this albumin if the systolic pressure is less than 80. He's also saying we need to give more fluids if we have low urine output. Now, when we're looking at burns, you know, what are the 2 biggest things that we watch for have to treat people with burns?
Respiratory.
Oh, good question. I think I'm thinking superficial burns. If it's inhalation, then we do want to look at respiratory. So you're not wrong. That's a good answer. So we lose a lot of fluid with burns. And so we're always battling.
Dehydration.
We're always battling dehydration. And then with the burns, we've literally burned away the skin's protective layer.
Infection.
And
Infection.
infection. Yeah. So with burns, dehydration and infection are the 2 things you're going to be battling the most. Because of that dehydration, and it's profound dehydration, this lady is getting like you guys know what a 2 liter of soda is? Like she's getting 2 of those up to two every hour. Like that's so much. That's 2 IV bags every hour. That's so much fluid. But a lot of times our patients need this because of that profound dehydration. So both of these are correct. And I would be the first to tell you, when I read through this the other day, I was going, oh man, which should I give first? Because the albumin will help. But the fluids are going to give us more bang for our buck because we have that low urine output. We know that she is profoundly dehydrated. The albumin will help some with that volume expander. It helps to kind of expand her volume. But if she doesn't have volume there to expand, it's not going to help as much. So we really want to first give those IV fluids, bump it up. She needs more. Then we can go ahead and give that albumin after that. And then we'll get the X-ray and the ABGs and all those. And like we were talking about, Agnes, in the real world, we'd probably be doing most of these at the same time, but it's wanting to check your critical thinking. It's wanting to say, if you only get to choose one of these, which is most important? And so hopefully some of these questions helped you guys think through, like, how do I choose the most important of these? All right, so that was really all I had for kind of our what's it called? The study for today. And if you weren't here when I first got on, really what I talked about was, with the test, I think a lot of students tend to struggle with that critical thinking about deciding what's most important. How do I prioritize things? And so, yes, use your ABCs, like airway, breathing, circulation, but also know if their airway and breathing are fine, they're doing okay, then you move to circulation. Circulation's the right answer if their circulation isn't doing well. The same thing, I also like students to think about Maslow's hierarchy of needs a little bit, right? Somebody might be crying and sad for something, and even though they're very loud and they're crying, if the next person is over here silently managing a heart attack, I probably am going to go see the heart attack person first because I want to manage this person who's sad from a situation, but I'm going to use Maslow's needs too to try to see what's most emergent as well. All right, any questions or things before we sign off? Not so much. Okay, well, thank you guys for hanging out with me tonight. Hopefully this will really help you. And just I love the flashcards and all the study tricks and groups and all that you guys are doing. So keep it up. It will be fruitful. You just have to, just don't give up. Keep trying. All right. Well, thank you guys. I will see you Wednesday. If you have any questions or need anything, feel free to reach out to me.
Thank you.
All right. Thank you guys.
Thank you.